I hope you all thoroughly enjoyed yesterday's entertainment program and the extensive banquet. I request all the delegates to kindly sign in for the morning session at the registration desk. Now let's dive back into our dynamic sessions for day 2 of the CME of Fanindranath Tota Anesthesia Update and the 19th Anesthesia Postgraduate Academic Program. Without further ado, we will start with the first lecture of the day. I would now like to call upon Dr. PANKAJ KUNDRA to the stage for his lecture on the pharmacokinetics of total intravenous anesthesia. Dr. PANKAJ is a senior professor in the Department of Anesthesiology and Critical Care at JIPMER and serves as the Dean of Pondicherry University. He has an impressive record of 129 publications in PubMed Index journals and over 3,000 citations. Let's hear from the icon himself. Over to you, sir.
A very good morning to all of you. Thank you for being here. And it's an honor to be at this podium and share my thoughts with you. Thank you, KMC Manipal, Dr. Anita, and rest of you. It's been a really entertaining yesterday's evening. And now let's get back to the academics. So the topic is about pharmacokinetics and TIVA. So what happens when we inject a drug into a human body intravenously? I hope am I audible properly? So let's say we give propofol. The moment you inject propofol into the body, the first thing which happens to the drug molecules is the plasma protein binding. And as soon as the drug molecules bind most commonly to albumin, there will be a bound fraction and an unbound fraction. Thereafter, the drug gets distributed to the entire body, and that is defined as the distribution or the volume of distribution. Once the drug is distributed, simultaneously, there is likely to be metabolism and excretion, and which accounts for the elimination of the drug from the body. So this is an important diagram, which basically tells you what happens to the drugs when you when you have injected it in the plasma. So there will be a bound drug, there will be an unbound fraction, which is the free plug. And then it has to actually traverse, goes into the interstitial fluid, and see the free drug concentration across this barrier is in equilibrium. From the interstitial fluid, it has to go into specialized tissues. And that requires active transport pumps, and diffusion barriers have to be transgressed. And therefore, at the effect site, like at the brain, the effect of the drug will depend upon its lipid solubility, degree of ionization, cardiac output, and cerebral blood flow. Hence, the plasma concentration does not correspond to the effect site concentration, and there is likely to be a delay or a lag period by the time you reach a peak plasma concentration to that what is achieved at the target organ. Now coming to some basic pharmacology. Let's start with the volume of distribution. So if it is a 70 kg person, you'll find that the apparent volume in which a given drug is going to be distributed when in a steady state is reached is actually defined as a volume of distribution. So you inject a milligram of kg of drug, it goes into the intravascular compartment, into the extracellular fluid, and then gets distributed throughout the total body water, almost to 42 liters. That's why it is called as apparent distribution. And then what you measure gives you the concentrations in milligram per liters. Therefore, the volume at which the drug has been fully distributed throughout the body and the system is in equilibrium, at that point you get what is defined as the volume of distribution. So after distribution, the drug has to be eliminated or excreted. So it follows two mechanisms. One is zero order kinetics, the other is first order kinetics. What's the difference between the two? In zero order kinetics, the rate of excretion is independent of the concentration of the drug in the plasma. While in first order kinetics, it's proportional to the drug concentration. Therefore, the half-life continuously shortens when you talk about zero order kinetics. But in first order kinetics, it remains constant because the rate of excretion is proportional to the drug concentration. And then if you plot a graph, you'll have drug versus time, and the other part would be log concentration versus time. So just to be a little more clear about first order kinetics, look at this fraction which is being eliminated. It is constant here, 0.15, 0.15. At every hour which you lead, a constant fraction of the drug is being eliminated. And this is the amount. And this is the amount remaining in the body. Therefore, this is a constant, and this is described as the elimination constant, or defined as KEL. The pharmacokinetic process occurs at a rate which is proportional to the concentration gradient of the drug in various compartments at a particular time. So this happens, and therefore, as the concentration of the drug falls or declines, the pharmacokinetic process progressively slows down. And once it slows down, then there is an exponential relationship between concentration and time, or the concentration gradient and time. And this is expressed by a bioexponential equation. One is an elimination constant, the other is a half-life. Now, what is elimination constant, which we saw in the previous slide? We said it is KEL, or it becomes absolutely constant. A fixed fraction of the drug is excreted. Here, what is defined is that at a particular time, you will find that the portion of the drug, or the fraction of the drug which is remaining, will be defined as the elimination constant for that drug. And if you talk about the half-life, you'll find that it is basically the concentration of the drug which has fallen to almost 50%. Let's say it is T half. Then if it falls to 50%, at what time it falls at 50% will be taken as T half for that patient. Now let's come to the compartment models, which are the basic essence of TIVAs or TCIs. The one compartment model defines that the drug is uniformly distributed throughout the body. And to that, you'll find that the body is a single compartment. An instant distribution will occur if the drugs are given instantly and are distributed instantly, and that is what the intravenous fluids will do. There will be rapid equilibrium between tissues and blood, and it follows first order kinetics, that is KEL is constant. In a two-compartment model, there are two compartments which have added. One is a central compartment, the other is a peripheral additional compartment. So there is going to be a slow equilibration, and there is going to be a biphasic elimination, which we saw in the graph below, where the pharmacokinetic process is basically proportional to the concentration gradient between the compartments at that particular time. So this is how the two-compartment model behaves. Now there is another addition to it, that is called a three-compartment model. So three-compartment model consists of a central compartment, a highly perfused tissue, and a poorly perfused tissue. So what happens? When you give a drug into the central compartment, it slowly equilibrates to the highly perfused tissues and to the poorly perfused tissues. And when you switch off the infusion, the flow of the drug or the diffusion of the drug is always going to be across the concentration gradient. So what do you see here? This has equilibrated even when you have switched off the infusion, the central compartment and the highly perfused, but the poorly perfused tissues, the concentration is still low. So there is a concentration gradient between the central and the poorly perfused, and you will find the drug will continuously perfuse to the poorly perfused areas till an equilibrium is attained. So even after you have switched off the drug, it doesn't mean that the entire drug has been eliminated. It will slowly keep coming into the poorly perfused, and then thereafter, when the concentration rises here, it will come back to the central compartment. Now there is another modification to it, which is called a multi-compartment model. So as we have seen that there is a rapid distribution between the highly perfused here, and you have a slow distribution to the poorly perfused tissues. So there is an equilibrium which will happen, and this equilibrium will actually be attained between the compartments, either the drug moving from central to the highly perfused or from the highly perfused to the central, depending on the concentration gradient. And similarly for the poorly perfused, as we have defined earlier. But there is a fourth compartment which is added here, that is the brain. Because most of the drug action is not in the central compartment, but the effect organ is the brain. So an effect organ compartment has been added, and this is where we need an equilibration between the plasma and the brain, or the effect site concentrations, which is determined by something called KE0. Please remember this KE0. This becomes the basis on which all the compartment, or all the TCI models have been formed. Because they look at the effect site concentrations, predict that, and compare it to the plasma site concentrations. So the rate of equilibrium between the plasma and the effect site concentration is determined by KE0. If the KE0 is high, or the equilibration will happen at a rapid pace. But if the KE0 is low, or the number is low, then there is going to be a delayed equilibration with the effect site. So this is the importance of the constant called KE0, which determines the equilibration between plasma concentration and the effect site concentration. So based on this multi-compartment model, the doses of the drugs have been defined. How do you determine what should be the loading dose of a particular drug? Let's say, for example, propofol. So the loading dose would be the volume of distribution and the plasma concentration. So if the plasma concentration, or the therapeutic plasma concentration of propofol, has to be 4 microgram per ml, and the volume of distribution is 0.5 liters per kg, then your loading dose will automatically be about 2 milligram per kg. That's what we give as an induction dose. Now let's come to the bolus dose. You have started with a loading dose. In between, when you are giving infusion, you need to give some boluses if your anesthetic depth is varying. So the bolus dose will again be defined by the volume of distribution in the central compartment, that is V1, and what is the plasma new concentration which you want to achieve, minus the actual concentration which is there in the plasma. That will decide what will be the bolus dose of the drug. What about maintenance? Because you give infusions. So maintenance is nothing but whatever drug is being cleared from the system, that has to be replenished. So therefore, maintenance dose would be clearance into the plasma concentration of the drug. And that is defined by V1, or the central compartment volume of distribution, into K10. That's a constant. So that's how these doses have been calculated for various models. Now, what is this PK and PD modeling? It depends upon two things. PK is pharmacokinetic plus pharmacodynamic parameters are integrated together. Pharmacokinetic means dose concentration relationship, while pharmacodynamic means the concentration effect. That is the clinical effect which you get from a particular drug. Let's talk about them in a little more detail. So the fundamentals of PK-PD modeling are that we should understand what is the effect site versus the plasma concentration, the clinical dose response data, integration of these two, and the context-sensitive half-lives. We'll go one by one. The effect site and plasma concentrations, if you look at this diagram, you'll find this is the effect site and this is the plasma concentration. So the plasma concentration is much higher than the effect site concentration. So that is the amount of plasma concentration you would require to achieve a satisfactory effect site concentrations. And see the slope of the curve. It is tilted towards the right side. That means there is a lot of variability for, let's say, CECP50, it's analogous to MAC 0.5. You'll find that there is a lot of variation in the concentration of the propofol in the blood. which can produce a similar anesthetic effect. So that's the problem which occurs with intravenous infusions, because they're all based on algorithms, not on real-time analysis. Therefore, when you compare them with inhalational agents, the graph is almost straight or a perpendicular or a vertical line, which means there is hardly any difference in the concentration of inhalational agent to give a desired effect at Mach 50 or Mach 95. So that's the difference you will have to accept when you use TIVA or TCIs, that this variability is likely to occur, and this variability is going to lead to chances of awareness which can happen in patients. And that is why whenever you practice TIVA or TCI, BIS or BIS or entropy is mandatory. Now, what are the factors which can affect the target site concentration? I had earlier told you about lipid solubility, ionization of the drug, cardiac output. These are certain related factors from the patients which can occur when we give such drugs to the patients. Let's say, for example, age. Now look at the BIS at different ages. This is the effect site concentration, and you will find the BIS is 60 with only 35% of the drug effect occurring across the age which is falling down. So all of these BIS values have been related to the percentage of the drug effect, and you see there is a gradual decline as it occurs with age. Hence, as the age advances, your TCIs or the models which you select have to be very specific to the age, comorbid conditions, and body mass. Let's come to the clinical dose response data now. We have finished with the effect side and plasma concentrations. Now here are the plasma concentrations of L-fentanyl, and these are the plasma concentrations of fentanyl. And this is the response or the EEG which is being charted against these concentrations. So at different concentrations, you'll find that at 1, you will get analgesia, where the concentration of fentanyl is between 0.25 to about 2.5. It produces respiratory depression when it is at about 2 to about 6, thereon and so forth. So the clinical effects which are produced by various drug concentration is what is called dose-effect relationships or pharmacodynamic relationship bit of the drug. So the fundamentals again for the other one is the integration of kinetic data. How do we integrate this dose response to the effect site concentration? Can we integrate these two? We can do that, and you can find that if the kinetic data is integrated, when you give an intravenous bolus of L-fentanyl and fentanyl, the peak rise is almost the same. The graph is almost same. There is no difference in it. Having achieved the same intravenous, having achieved the same concentration in the blood, does it make any sense to know what is happening at the effect site? So in the blood, the concentrations are almost matched. But when we look at the concentrations at the effect site or the brain, you'll find the L-fentanyl effect has reached its peak and a desired concentration is achieved. But look at the fentanyl graph at the brain. It is much lower. That means the desired effect or anesthetic effect is not yet achieved by fentanyl, which has been achieved by L-fentanyl. What about the offset? If you look at the offset again, you'll find that the L-fentanyl at the brain site is cleared off much faster, and as compared to fentanyl, where there is persisting effect on the brain once you have given a fentanyl dose. So there is a slower offset. So it will be a slower onset than L-fentanyl and a slower offset than L-fentanyl at the brain site, despite having the same curve at the plasma concentrations. Let's come to the last part, the context-sensitive half-times. The elimination times here you'll find that it is basically defined in context to stopping of the infusion. So the moment you stop an infusion and there's a 50% drop in the plasma concentration, that will be the context-sensitive half-time, where the context is basically the infusion duration. Now coming to the pharmacokinetic models, please stop me when the time is over, I'll just stop there. The pharmacokinetic models are computer controlled, and you will have patients' expected drug concentration is continuously calculated by computer, and it is based on algorithms. There is no real data which it is fetching from the patient. So it's based on a lot of assumptions. So what is desired? You need to program with the desired concentration, the plasma concentration, and the administration is based on the BET regime. The adjustments of the infusion rate according to the BET regimes are made every 10 seconds, and it is something analogous to an automatic vaporizer. So this is how the target and control infusions work. So what is this BET? BET means bolus dose to fill the central compartment. Elimination is rate constant infusion, or the elimination rate which we talked about, the time constant and the half-life. So according to those algorithms, the elimination is decided for a particular drug. And then it is the transfer of the drug across the different compartments, the rapidly equilibrating compartment and slowly equilibrating compartment. So for propofol, it is the bolus dose is about 1.5 milligrams per kg. Elimination, they say you will have to give about 10 milligram per kg per hour, and there is an exponential decreasing rate. So at about 10 minutes interval, your doses should start coming down to 8 and 6 milligram per kg per hour. So the TCI models are basically two, which we have all understood. One is a Marsh model, the other is a Snyder model. Marsh model basically achieves the target concentrations according to the plasma concentration, whereas Snyder model takes into account the effect site concentrations. So there are different type of Marsh models. Here you will find that there is Marsh model which has a KE0. As I told you, it is the equilibration which occurs between plasma and the brain, which is 0.26, which is a slow. And there is a rapid one or a fast one where the KE0 is high or 1.2. This is called a modified fast model. So how does these two models differentiate from each other? It's basically based on the EEG effect activity, and the discrepancies are basically seen, which are markedly different at different sites according to the elimination constants, and there is a different effect time profile for the patient. So what is this different effect time profile for propofol, how they have been based? So it can be that you have set the effect site target of 3 microgram per ml, which is predicted by the Marsh model. It can be slow or it can be fast KEOR. So what is the difference between the two? If you find between the difference between the two, the peak concentrations which are achieved in the plasma and at the effect site when they merge is about 3.9 when it is taken into account a KE0 of 0.26 per minute. But when it has taken a fast KE0, that is 1.2 per minute, there is a fast equilibration, and T peak at the effect site and the plasma is about 1.6 minutes. So what does it imply clinically? Here you will have to give a greater bolus of about 1.9 milligrams per kg to achieve this target concentration as fast as possible. Here you might have to give a smaller bolus of about 1 milligram as compared to 1.9 to achieve the same target effect as fast as possible. But the final predicted effect has the same magnitude but is reached faster with the fast KE0. So the hypothetical real effect which was seen when they compared to these two models, they found that KE0 of 0.6 per minute is probably the most ideal one, and that is the way the new or the Thompson model was created, where they use where you use the visual reaction time to see the stable deepening and lightening of the patients, and the best KE0 which they defined was 0.6 per minute. Now pharmacodynamic synergy. You normally administer the narcotics along with propofol. So when you give a pharmacodynamic synergy, you'll find that there is some amount of correlation, and the amount of propofol required is much less as soon as you start giving a narcotic along. And these are the optimal dose ratios which have been defined. For fentanyl, it is according to the time, the dose varies and it increases to 68 minutes. That is the microgram per ml which you get here, and the fentanyl which slowly comes down. So the combination of propofol, fentanyl, these are the basic numbers which have been given. I think you will find it in any of the books, but if you want to take a snapshot, you can take it. Once you have set your infusions at these rates, what happens to the recovery? How do we chart out how the patient is going to recover? So that is done by charting out and seeing what are the best optimal ratios of the drugs, which are done by the concentration decay curves when we administer two drugs simultaneously. So when you are giving L-fentanyl and maintaining a plasma level of 90 nanograms per ml, and you are giving propofol to maintain a blood level of 3.5 microgram per ml, the concentration at which 50% are predicted to regain consciousness will be at the peak of this parabola. So that is the amount which will be taken when you have to, when you are giving these two drugs to predict what should be the actual awakening time. So this is how the concentration or emergence would be taken into account of these particular drug, and that depends upon the optimal drug dosage ratios. Shall I continue for 2 minutes more? Okay. So the major concern about TIVA and TCI is awareness. This is one of the review articles in 2011, and believe me, nothing has changed thereafter. They said use potent inhalational agents rather than TIVA if possible, because there is a lot of patient variability which can happen. So they try to look at the relation between the predicted values and the measured values, and believe me, there was a lot of scatter. And when they compare to the BIS, look at where the BIS is and where the concentration of the measured concentration of the drugs are. So there is also a problem when you look at BIS, it may not correlate well. The scatter is a lot and the possibility of awareness still exists. When they look at the different boluses and at short times, long infusions, TCIs and boluses, using EEG as a surrogate marker, what happens to these patients? These patients which are below this R square line are the ones who are in danger of getting or witnessing awareness. So whenever you're using TCI, TIVA, it's a word of caution, make sure you have BIS at hand. So these are the guidelines for safe total intravenous practices. And if you look at the joint statements, almost 20% of NAP5 reports of awareness have occurred, and EEG monitoring should therefore be continued until full recovery from the effects of neuromuscular blockade. So when you want to use TIVA, clinical assessment like these, giving us some sort of a noxious stimulus should be done, and use neuromuscular paralysis only after lack of X response to jaw thrust is achieved. BIS is the only option which you have, but you have something called as a TIVA trainer, which you can, it's a simulation free software which you can download, and it is good enough. It gives you it predicts the different plasma and the effect site concentrations. You can use combination of the drugs, and this is how the graphs will come when you can get the blood concentration effect site, and you can decide when to decrease your infusion rate to maintain at the maintenance rate. The TIVA in obese and in the patients who are elderly is different. Generally, Marsh model is used because it can give you a maximum of 150 kg. But if you use Minto and Schneider, it is applicable to BMIs of 43 in males and 36 in females. Pharmacokinetics for propofol here is generally taken as total body weight. For remifentanil, it's the lean body weight, and you target the effect site concentrations. For elderly above 65, avoid triple low blood pressure, BIS and MAC, because these three things, if they happen, they can cause problems to the patients. And pharmacokinetic models which are used for propofol and fentanyl, you target the plasma concentration and effect site target, but make sure patient doesn't have hypotension. Remifentanil target the effect site concentration, and the plasma concentration can be allowed to overshoot by small values. sensitive to changes in plasma concentration, start with a lower dose. All these patients are very sensitive to these concentrations. So start with a lower dose and move upwards and target a BIS of about 50 to 65, not 30 to 40. In the end, when you use these infusions, the flip side is you're generating a lot of biomedical waste. These are all single-use plastics. A lot of them are being recycled, being picked up by people, sterilized and repacked and given to us. So make sure, as far as possible, we reduce our biomedical waste in the hospital. You know how much do we incur as per the 2022 data? It is almost 1.5 kg per patient per bed. That is what is being, that is the amount of biomedical waste which you are generating. So be mindful of that. Thank you very much.
Thank you, sir. We'll be taking questions from the audience a little later. Moving on. The next lecture will be by Dr. RAMKUMAR VENKATESWARAN. Dr. RAMKUMAR has served as a professor and former head of the department at KMC Manipal and has over 30 publications in index journals. He is the trustee of Mission Smile and past editor-in-chief for Airway Journal. Now let's listen to the lecture on physiology of one lung ventilation from the legend himself. Over to you, sir.
It's always a pleasure to be back in my, what should I say, home department. And when I entered this hall, which is not so fancy, about 40 years ago, it was a single large hall as it is today, but didn't have all this fancy equipment at that time. And this is where, I think in the year 1986, I gave my first APGAP lecture. I think Dr. Rao is in the audience, and he and I actually combined together to give a talk about poisoning. I gave the talk on basic principles of poisoning, and Dr. Rao followed with specific management of poisoning. And that was a truly exhilarating experience, and I can't believe that I'm back again after 4 decades almost to be speaking in the same room where I started my career as a speaker. Can I have the timer turned to me, please? Yeah. Thank you. Yeah, you can start the timer. Thank you. Right. So the topic for the next 20 to 25 minutes is going to be on physiology of one lung ventilation. And I thought after the beautiful lecture by Anita yesterday, I'll take a leaf from her presentation, where she said that the heart beats from the womb to the tomb. And I think that's true for every single body function. It doesn't matter whether it's the heart or the lung or the kidney or the liver or the brain for that matter. I think every organ continues to function from the time the baby is in the uterus till the time, of course, we turn into the tomb. Okay. So the other thing is, I think, taking from what we saw yesterday in the entertainment, and also what we saw whole day yesterday, and also what we saw, what we see at every conference, we find speakers standing up and talking. You don't find speakers lying down and speaking. You don't find people in all kinds of other positions giving lectures. And that's the reason. The reason for that is that most body physiology, especially respiratory physiology, works best in the standing position. All our respiratory functions are best in the standing position, and that's the reason why we're able to speak forcefully while we are in the erect position. And the reason for this is in the erect position, the ventilation perfusion matching is best, right? Now, when you talk about the lung, we need to look at how well the lungs are ventilated, the various parts of the lung. There is a difference, and that's the reason why we need to start to understand this first before we go on to the various other body positions that are taken up at the time of an anesthetic. Now, change in body position to supine from erect position, which is the position in which most of us start the anesthetic in the supine position. For some procedures, we place the patient in the lateral decubitus position, and like for lung and thoracic surgeries, which is going to be the primary focus of my talk in the next 20 minutes or so. So this, fortunately, maintains the same pressure gradients before we induce anesthesia, before we induce muscle paralysis. So in the erect position, there is a top to bottom gradient, whereas in the supine position and the lateral decubitus position, it is supine positions from the front of the chest to the back, and the lateral decubitus positions from the non-dependent lung towards the dependent lung. And that's about the only difference. But the moment we put the patient in a lateral decubitus position, which is necessary for most lung and thoracic surgeries, we anesthetize them and we paralyze them, and of course the surgeon opens the chest and starts operating. A lot of changes occur in the ventilation and perfusion matching, and that influences gas exchange. And that's the reason why this topic is important for us to understand as anesthesiologists. Now remember that there are two types of ventilation, perfusion, mismatch. When ventilation is in excess of perfusion, this mismatch is known as wasted ventilation, or we also call it as dead space ventilation. And remember at the start of the lecture itself that when there is more dead space ventilation, what gets affected more as far as gas exchange is concerned is the CO2 elimination, carbon dioxide elimination. Whereas when perfusion is in excess of ventilation, we call that excessive perfusion. And this is also known as by the term of shunt. And what does shunt affect? It affects oxygen uptake more. And the primary reason we all breathe is to take up oxygen and give out carbon dioxide. And remember that when there is an increase in the ventilation vis-a-vis perfusion, we contribute to dead space ventilation, leading to CO2 accumulation in the body. And when there is excessive perfusion, it leads to a drop in oxygen levels in the blood. We will cover this topic of physiology of one lung ventilation under the following headings. We'll talk about ventilation perfusion, the erect, spontaneous breathing patient, as a basis of our understanding of what will happen the moment we place our patients in different positions. And we'll go on to see in the lateral decubitus position. We'll go on to see what will happen once we anesthetize and paralyze these patients. And finally, when the surgeon opens the chest and starts operating on the non-dependent lung or the non-dependent thoracic cavity, what are the changes that happen? Finally, we'll have a very brief look at what's called hypoxic pulmonary vasoconstriction, because a topic on physiology of one lung ventilation is not complete unless we talk about the phenomenon, the built-in normal phenomenon of hypoxic pulmonary vasoconstriction. I do need a pointer now. Okay. So here we go. So this is a diagram which shows the distribution of perfusion in the erect position. And it goes, common sense says that when blood enters at the hilum of the lung, the mean pulmonary arterial pressure is roughly in the range of 8 to 20 millimeters of mercury. And you can take 12 millimeter mercury as an example of the average pulmonary arterial pressure. And that is enough to raise the blood from the hilum of the lung to the top of the lung in the standing erect position. As the blood goes into the hilum of the lung and starts going downwards towards the base of the lung, the pressure gradient is going to increase. And therefore, from the hilum down towards the lung, the perfusion actually increases. So if you look at the perfusion at the top of the lung, in most instances, there is hardly any perfusion at the top of the lung. And that's what we call zone 1, where the alveolar pressure is higher than the pulmonary arterial pressure, which is in turn higher than the pulmonary venous pressure. In the lung, what is slightly different from every other organ is that there is also an air-blood interface, and this creates an influence on the distribution of perfusion. Coming to zone 2, you can note now that the alveolar pressure has moved between the pulmonary arterial pressure and the pulmonary venous pressure. And now, what determines the flow of blood through zone 2 is the difference between the pulmonary arterial pressure and the alveolar pressure. So that gradient is there, and that's why you find to the right, you find that the blood flow has started slowly increasing out there. Zone 3, the same phenomenon continues, and you find the blood flow increases even further. And zone 4, fortunately, it doesn't happen every time, but when a new pressure called the interstitial pressure creeps in between the pulmonary arterial pressure and the pulmonary venous pressure, you find that sometimes there is movement of fluid from the intravascular compartment to the extravascular compartment, and so that's what results in pulmonary edema. So the gist of this slide is that perfusion increases in the erect position from the top of the lung to the bottom of the lung. Now let's see what happens to the ventilation. Consider the alveolus like a balloon, and what distends this balloon is the pressure difference within the alveolus, the difference between the pressure inside the alveolus to the pressure outside the alveolus. So P-I-N minus P-O-U-T, out. So the pressure within the alveoli can be taken as more or less constant, whether it's from the top of the lung to the bottom of the lung. The intra-alveolar pressure, as we all know from respiratory physiology, hardly changes from maybe plus 2 centimeters of water to minus 2 centimeters of water. And you can take an average of 0 for our mathematical calculations. We won't make a huge difference or a huge mistake by assuming that the intra-alveolar pressure remains more or less constant at 0 centimeters of water, though it actually ranges between minus 2 to plus 2 centimeters of water. Now, what happens to the pressure outside the alveolus? Outside the alveolus, if you can imagine, there is always a tendency for the alveoli at the top of the lung to fall away from the pleura. Of course, because we have an intact pleural cavity, the two pleural surfaces are opposed to each other, and they keep the entire lung expanded at all times. But as you move from the top of the lung to the bottom of the lung, there is a pressure gradient, as you can see on the left side of this diagram. Taking the height of the entire lung to be around 30 centimeters of water, and the average density of the lung to be 0.25 centimeters, about 1/4 of a solid organ, you find that for every change of 4 centimeter height from the top to the bottom of the lung, there's a change of pressure, intrapleural pressure, by 1 centimeter water. So you take the height of the lung to be 30 centimeters of water, divide 30 by 4, and you get a value of 7.5 centimeters of water. So what this means is that the pressure outside the alveoli, the extra alveolar pressure at the top of the lung, is going to be more negative than it is at the bottom of the lung, as you can see in the second bullet point here. So the intrapleural pressure is actually minus 10 centimeters of water at the top of the lung, and it is less negative, minus 2.5 centimeters of water at the bottom of the lung. And the difference, as you can see, is 7.5 centimeters of water, created by the fact that, as I explained in the next slide. So I also mentioned that the way the alveolus expands depends upon the pressure gradient from within the alveolus to the outside, pressure in minus pressure out. And if you take that as an example, you can find that the top of the lung, at the top of the lung, the intra-alveolar pressure is same. The intra-alveolar pressure is same throughout. The extra-alveolar pressure is about minus 10 centimeters water there and minus 2.5 centimeters water at the bottom. And that makes an impact on the way the ventilation happens to the top of the lung. The alveoli at the top of the lung are already maximally expanded. And as you go down the lung to the mid-zone, they are optimally expanded. When you come to the bottom of the lung, they're all kind of crushed. Because of the weight of the lung, they are crushed. And they have got an ability to expand more when the patient breathes. And that's what is shown here. I'm not able to get this working. Please show me. Ordinary point out. I guess my hands are not as steady as the young ladies. Okay. So you have a transpulmonary pressure gradient, as I explained, of 5 centimeters of water in each of these brackets here. And the alveoli at the top of the lung, you see the vertical height of these lines. The vertical height of the alveoli at the top of the lungs is much less than the vertical height at the bottom of the lung, which essentially means that the volume change happening for the same transpulmonary pressure gradient is much more at the bottom of the lung as compared to the top of the lung. And that's why the ventilation also increases from the top to the bottom of the lung. Now, this is the classical 9-slice model as described by Sir John B. West. And he just divided the lung into 9 slices. The first column to the left shows volume percent, and that says 7 for the top slice, 11 for the slice at the hilum of the lung, and 13 for the slice at the bottom of the lung. So when you add all these numbers that come in this column, it comes to 100% volume of the lung. The second column talks about the alveolar ventilation in liters per minute. The third column talks about the perfusion in liters per minute. And the middle column, the fourth one, gives you what's called the ventilation-perfusion ratio. So this kind of summarizes what I've spoken about until now. It says that the ventilation is higher at the top of the lung, okay, and you get a ventilation-perfusion ratio of 3.3. At the hilum of the lung, it's 1. That means ventilation and perfusion are perfectly matched. And at the bottom of the lung, you find a ventilation-perfusion ratio of 0.63, which means the perfusion is in excess of ventilation. So at the top of the lung, you get more dead space ventilation. Around the hilum, you get perfect matching of ventilation and perfusion with a VQ ratio of 1. At the excessive perfusion as compared to ventilation, and that is what contributes to shunt. And the last 3 columns tell you about the PO2, PCO2, and the nitrogen partial pressures in the alveoli at these 3 levels. PO2 increases, as you can see, from 89 to 132 millimeters of mercury from the bottom to the top. And that's a change of about 40 millimeters of mercury from bottom to the top. The PCO2 decreases by 14. And the gist of this particular slide is that as there is more dead space ventilation at the top of the lung, that affects CO2 elimination more, as we mentioned in the earlier slides. And the shunt is more at the bottom, that predominantly affects the oxygen uptake. And these are the 3 lines that are intersecting. You find that the blood flow and ventilation, The x-axis shows the rib numbers. To the right of the x-axis is the top of the lung. To the left of the x-axis is the bottom of the lung. And you find that as the ventilation and perfusion are looked at from the top to the bottom of the lung, both of them increase. Both ventilation and blood flow increase. And the blood flow increases at a far more rapid manner than the ventilation. And eventually the curved line that you see is the ventilation-perfusion ratio. And you can see that all these three cut at a point where the ventilation-perfusion ratio shown on the right side y-axis is 1, and that happens roughly around the hilum of the lung or the rib number 3. So this much about the basic understanding of the physiology. Now let's see what happens in the lateral decubitus position, which is the position which I mentioned is the position in which most lung surgeries are performed. Now, in this particular slide, I've said that the patient is awake, spontaneously breathing, and has a closed chest. And as I mentioned earlier, the same gradients will apply here as well as we saw in the erect position, except for the fact that now the gravity dependence will make sure that the up lung or the non-dependent lung will now act like zone 1 and zone 2, and the bottom lung, which is the dependent lung, will now act like zone 3. So the dependent lung gets better perfused. The dependent lung also gets better ventilated. The only difference is that now the patient is in the lateral decubitus position. The non-dependent lung is primarily in zone 2, and the dependent lung is primarily in zone 1 and zone 3 rather, and zone 1 is practically absent, which again is shown here diagrammatically. Patient is in the lateral decubitus position. You can take it as right lateral or left lateral. But the non-dependent lung, which is on top, is actually more in very little zone 1, and most of that is in zone 2. And the bottom or the dependent lung is now mostly in zone 3. That's about the blood flow. As far as the ventilation is concerned, to the left of this diagram, you find the erect position, which we have hopefully understood by now. So the alveoli at the top are maximally distended already. The alveoli at the bottom have a lot of potential to distend still, as you can see in the erect position on the left side. The moment you place the patient in the lateral decubitus position, what happens? You're not anesthetized the patient yet. Your patient is awake, your patient is spontaneous. Let's say we're just taking rest in the afternoon. You're taking an afternoon nap in the lateral decubitus position. What happens? Your dependent lung gets both better perfused and better ventilated, whereas your non-dependent lung gets less perfusion and less ventilation, similar to what happens in the erect position. Now we add on a factor of anesthetizing this patient and paralyzing this patient. One thing that we probably need to remember is that when we have a patient a person breathing spontaneously in the awake, closed chest, lateral decubitus position, because of the pressure of the abdominal contents on the dependent hemidiaphragm, that hemidiaphragm is stretched. And we know that any muscle that is stretched will contract better. When the preload is better, it will contract better. So in the awake, spontaneously breathing, closed chest patient in the lateral decubitus position, you'll find that the dependent lung in a patient breathing spontaneously, not yet anesthetized, that lung is going to also now ventilate better. Another reason why that happens. Now, the moment you anesthetize and paralyze a patient in a closed chest position, what happens next? Once you remove the effect of spontaneous breathing, the dependent lung, the entire diaphragm, of course, gets paralyzed, but the dependent lung, which was now earlier ventilating better because of the spontaneous breathing, you now paralyze that patient. So the dependent lung gets poorly ventilated. The non-dependent lung gets better ventilated. The other reason also is that the weight of the mediastinum now presses down upon the dependent lung. The moment the patient is in the lateral decubitus position, the mediastinal contents, be it the heart, the other tissues in the mediastinum, they press down on the dependent lung, and that kind of squeezes the dependent lung and allows the non-dependent lung to ventilate better. The non-dependent lung is well ventilated, therefore. Perfusion goes by gravity, and therefore, to understand the second bullet point, the dependent lung is well perfused, poorly ventilated, whereas the non-dependent lung is well ventilated and poorly perfused. Until now, we have not even induced anesthesia, we've induced anesthesia, but we've not opened the chest as yet. So you find that there is no change in distribution of blood flow. The non-dependent lung continues to get less perfusion. The non-dependent lung no longer is confined by the chest wall once you open the chest. And that's common. We see that if you have the chest open and you're continuing to do two-lung ventilation, there is nothing. The intrapleural pressure has been negated by the atmospheric pressure. And when you deliver a positive pressure breath, the non-dependent lung actually ventilates better. Now the surgeon is ready to operate, and what does he or she do? She collapses the lung. And surgical handling will divert ventilation from the non-dependent operative lung to the dependent non-operative lung. Also, the weight of the mediastinum was already pressing down there, remember, and now that the surgeon has compressed the lung to facilitate surgery, more of the ventilation is now being moved to the dependent lung. Dependent lung is already getting better perfused. So this is what happens in an open chest. When the surgeon is ready to operate, the non-dependent lung, you find that the pressure of the abdominal contents on the non-dependent lung is less as compared to the lower or the dependent lung. Surgical positioning, jackknife position, whatever position that the surgeon uses to open up the non-dependent lung will also compromise on ventilation. The mediastinal contents are pressing down on the lower lung, and the chest is now open. So once the chest is opened, the lung is free to move until the surgeon is ready to operate. So overall, what happens? The dependent lung, in the lateral decubitus position with the open chest, the non-dependent lung, until the surgeon starts operating, will get better ventilated. The dependent lung will get better perfused. But once the surgeon starts operating, he or she will collapse the lung, up lung, and now the ventilation starts getting pushed to the lower lung. Now, once we start, when the surgeon starts operating, the conventional management of one lung ventilation is to switch to what is called an FiO2-1, a tidal volume of 10 to 12 ml per kg, and a respiratory rate to maintain an arterial carbon dioxide tension of 40 millimeters of mercury. This is what is conventionally done the moment we induce a one lung ventilation. But what happens, we have seen that there is the ventilation and perfusion have now been disturbed, and therefore now the top lung, if you allow the surgeon to operate and compress the lung completely, that lung is not going to get ventilated, but will still continue to get some perfusion, and that's going to continue contributing to some degree of shunt. So we try to negate that by using a conventional management of one lung ventilation. The other things that we can do, the surgeon doesn't want the lung to be blown up and down with each ventilation, and therefore we can collapse the operative lung. We can give a CPAP of 10 centimeters of water to the non-dependent lung. What does a CPAP do? It distends the lung to some extent, but the lung remains steady. And the surgeon is still comfortable operating on a steady lung rather than a lung that keeps getting blown up and down towards him as he operates. So the application of a CPAP of 10 centimeters of water to the non-dependent lung improves the ventilation perfusion ratio. We can also use what's called high-frequency ventilation to the non-dependent lung. I just added this so that we understand why we do certain maneuvers because of the change in body physiology. High-frequency ventilation, as we understand, creates ventilation of the lung, but just flutters the lung. It's a very high-frequency ventilation. There's no active inspiration and expiration happening. And both CPAP and high-frequency ventilation will not disturb the surgeon's operative procedure. We can also add a dependent lung PEEP of 10 centimeters of water. This recruits lung volume that is lost due to surgical positioning, surgical retraction and manipulation, and the mediastinal weight acting on the lower lung. And this again kind of distributes the ventilation and perfusion and improves the overall situation. We now come to the last part, which is the hypoxic pulmonary vasoconstriction. I'll cover this very briefly. The details are all in the lecture notes. In most organs, with the exception of the lung, hypoxia and hypercarbia in any regional circulation of the body, you can take the lung, the liver, the kidney, the heart, whatever, brain. In any of these organ regional perfusions, hypoxia and hypercarbia is a potent stimulus for vasodilatation. And quite the opposite happens in the lung. The lung is unique in that hypoxia and hypercarbia actually produce a vasoconstriction. And this is a kind of a protective mechanism. When some area of the lung is not getting adequately perfused or ventilated, there are receptors in the alveoli which sense the partial pressure of oxygen in the alveoli. And they work in a range of 40 to 100 millimeters of mercury. When they sense that there is some part of the lung that is not getting ventilated adequately, that area is getting a lower pre-alveolar O2, it just shunts the blood away to the ventilated areas of the lung. And this is actually a protective mechanism which tries to re-establish the ventilation perfusion ratio. So hypoxic pulmonary vasoconstriction moves blood from underventilated units to better ventilated areas of the lung and thereby reduces the VQ mismatch that is produced during one lung ventilation. Now, as Pankaj has described in a lot of detail in the first lecture on TIVA, intravenous agents fortunately do not affect hypoxic pulmonary vasoconstriction, nor do inhalation agents, the modern agents such as isoflurane, sevoflurane, and desflurane, if you use them in concentrations less than 1 mAq. So we are still safe, even though we are collapsing one lung. The natural phenomenon of the hypoxic pulmonary vasoconstriction helps us, even if you are giving GA with MAC values of volatile agent less than 1. And if you're giving TIVA, TIVA is known to be the least counter-effective to the hypoxic pulmonary vasoconstriction. But the only problem is, as Pankaj has described in great detail, how to maintain the right levels of TIVA in, when you're using just TIVA alone to maintain the anesthetic. Right. So in summary, what we talked about in the last maybe 20-25 minutes is that matching of ventilation and perfusion is best in the erect individual breathing spontaneously. As we are all doing now, you're either sitting up in a chair or I'm standing up here. So our ventilation and perfusion of the lungs are now best matched in this position. Assumption of supine and lateral decubitus positions in the awake state maintain the same gravity-dependent distribution. In the supine position, as I described, if you're lying down, the gradient is now from the top of the lung to the bottom of the lung, of both lungs. Suppose the patient is in the lateral decubitus position, the top lung or the non-dependent lung becomes zone 1 and zone 2 as far as ventilation is concerned, and the bottom lung, the dependent lung, now becomes the gravity-dependent lower part of the lung, as happens in the erect position. Ventilation perfusion mismatch affects both oxygen uptake and carbon dioxide, but we know that when there is excessive, the carbon dioxide elimination is affected much more than the oxygen uptake and vice versa. Induction of anesthesia with muscle paralysis and opening of the chest, initiation of one lung ventilation, progressively uncouples this ventilation perfusion homeostasis and creates worsening hypoxemia. And all the techniques that we talked about that we use for one lung ventilation tries to negate all these adverse effects of one lung ventilation. If Anjana is in the audience, I'd just like her to stand up. Anjana is one of our senior residents from Manipal who actually helped me with all the illustrations featured in this presentation. Thank you, Anjana, for that. And of course, thanks to the Department of Anesthesiology at Manipal. I wouldn't call it the Department of Anesthesiology at Manipal. As I mentioned at the start of my talk, I have been here for close to 4 decades, and that's a long time. And I have fortunately been directly or indirectly involved in all the 19 APGAPs until now. I missed only 3 APGAPs. The first one was 1984. I had not joined Manipal yet. Elsa was here, right? And of course, I trained one of my postgraduates from JIPMER and sent that person to give a talk in the 1984 lecture. 1985 onwards, I was very actively involved. And a couple of years I missed because of one, I was out of the country, 2, my mother was unwell. But barring these 3 APGAPs, I think I've been very fortunate that over the last 40 decades, I've been around to witness how things have changed over the years. I just took a minute extra because I got a bit emotional. Thank you so much for the patient hearing.
Thank you for the lecture, sir. Moving on to our next session. Next, I would like to welcome Dr. Matthew George, an alumnus and a gold medalist of the batch 2007 of KMC Manipal. Dr. Matthew currently serves as an associate professor at Amrita Institute of Medical Sciences and Research Center, Kochi, with a distinguished focus on pediatric neuroanesthesia and anesthesia for trauma. He has made significant contributions with numerous publications on pediatric neuroanesthesia, craniosynostosis, and intraoperative neuromonitoring. We are delighted to have him with us today to share his expertise on neuromonitoring for spine surgery.
Good morning, everybody. At the outset, I would like to thank the organizers of APGAP 2024 for truly honoring me with this lecture. At the outset, I would like to thank all my teachers, most of whom are actually present here. There are quite a lot of them to name. I'm not going to name all of them, but I would like to just jump into my lecture, I guess, since time is short. So the topic allotted to me is neuromonitoring for spine surgeries, how I do it. So at the end of this lecture, all the listeners hopefully should be able to understand why we need to monitor the spine for major spine surgeries, and they will be able to understand, hopefully, the rudiments and basic principles behind most of the modalities that are being used for monitoring spine surgeries in the current day, which includes evoked potentials, EMG, and monitoring spinal reflexes, and also a basic overview of how to troubleshoot issues with neuromonitoring. Now, whenever you undertake major spine surgery, there is a small but significant risk of spinal cord injury, which can result in significant disability to the patient. And this is really devastating not only to the patient, but also to the treating team. So the incidence of motor deficit or paraplegia has been reported to be around 3.7 to 6.9% of all major spine surgeries when you don't use neuromonitoring. This can be reduced to as low as 0.5% when you're using some monitoring, but I'm sure most treating teams would like to get that number as low as possible, because a neurological deficit that is significant is something that the patient will have to live with for the rest of their life. So we'd like to get it as close to zero as possible. So now in the early days of spine surgery, when we used to operate in Manipal with Harrington rod fusion for scoliosis, the spine was really in danger of damage mainly at the step of spine straightening because of the variation in technique. You were basically using sublaminar wires, so the cord was not really in any great danger. But as surgical techniques have evolved, placement of pedicle screws have put the spine in real danger, and there is real risk at multiple stages of the surgery. So the wake-up test was not deemed to be an adequate and continuous enough monitoring of the spinal cord during surgery, and so there has been a quest to find continuous and patient-independent assessment of spinal cord integrity. So now just touching upon these events. So spine can be injured due to multiple causes. So the most, I think the most worrying would be the hardware actually impinging into the spinal canal. Surgical intervention can also result in narrowing of the spinal canal due to fractures or dislocations of the spine, which cause narrowing of the spinal canal and compression of the spinal cord. And probably the most important issue is actually spinal cord ischemia. So if you look at this diagram that we have here of the spinal cord, you find that the anterior spinal artery is a single artery, and it is actually supplying a very large portion of the spinal cord. That is, the anterior 2/3 to 4/5 of the spinal cord is supplied by a single artery. And it is through this anterior part of the spinal cord that you have your lateral corticospinal tracts and the anterior corticospinal tracts, which are responsible for the motor control of the whole body. And because it's a single artery, this part of the spinal cord is extremely prone for ischemia-related injury. Now, somatosensory evoked potential was the first widely used modality for intraoperative spine monitoring. This basically involves stimulation of peripheral nerves and monitoring for a cortical response across the scalp at the postcentral gyrus. So the common sites for monitoring are the median nerve and the posterior tibial nerve. And we generally say that the SSEP is significantly suppressed when you have an amplitude drop of more than 50% or an increase in latency of more than 10%. Now, the SSEP basically monitors the dorsal column. Okay, so this impulse basically goes up the dorsal column. It reaches the brain stem. At the midbrain, it reaches the medial lemniscus, where you can monitor it using a C5 FPZ montage, and you get a very subtle SSEP tracing over here, but we primarily rely on the cortical SSEP waveform. So from the lower limb, you get the P37 N45 waveform, which you actually can monitor for lower limb. In the upper limb, you actually have P19 and N23. So it is well known that anesthesia will suppress the SSEP. Volatile anesthetics are the most implicated culprits for that, especially if you try to aim for MAC more than 0.5. But generally, if you keep your MAC of volatile agents below 0.5 and supplement it with intravenous anesthetic, you will be able to get a reproducible SSEP. And trying to add etomidate or ketamine to the anesthetic mix has been described to improve the amplitude of your SSCPs. And paradoxically, actually, muscle relaxation will actually help the MEP amplitude to be amplified because it decreases the EMG background noise. But in this current era of increasing use of motor evoked potentials, we are not able to use muscle relaxants that regularly. So that is an added impediment to using SSCPs. But most centers currently do use intravenous anesthesia with propofol or even a barbiturate-based technique, so which is widely considered to be the most compatible with SSCP monitoring. Now, SSCP changes can be observed in up to 2.5 to 65% of spinal surgery patients, and if you have a change in your SSCP, you have to intervene very urgently. So the anesthetic interventions include lightening the anesthetic, correcting hypotension or hypoxia, increasing the hematocrit, and the surgeon may opt to decrease the angle of correction of the spine or remove the implants in total. So SSCP actually has its limitations because it primarily monitors the posterior column. It does not always correlate with actual neurological injury. So in 1 in 1,500 patients who undergo spinal surgery with only SSCP monitoring, you can still get an undetected neurological injury, which again is extremely devastating. So SSCP also has other drawbacks in that it takes some time to average the signal. It can take up to a minute or two, depending on the amount of background electrical signal that is present in that OT, and it cannot be repeated frequently because of that. So because of that, motor evoked potentials has more or less replaced SSCP for major spine surgeries because it's a better monitor of the functional status of the spinal cord, and it provides information on the anterior spinal cord and the internal capsule. Motor evoked potential basically involves direct stimulation of the motor cortex by placement of corkscrew electrodes on the scalp that overlies the motor cortex. This is basically transcranial electric stimulation, though magnetic stimulation has been described in lab situations with animals. It's not been translated into the operating room yet. So transcranial electric MEP basically uses very high frequency, high energy current across the scalp onto the motor cortex, and you can select a wide montage of muscles to be monitored. There has been some interest in monitoring the D wave by placing electrodes in the epidural, which has not widely been practiced because of lack of laterality in D wave monitoring. But the advantage of D wave monitoring is that it is less sensitive to anesthetic technique and choice. So So the motor pathway starts from the cortex across the internal capsule, decussation at the level of the medulla, and it goes down via the lateral corticospinal tract till the level of the spine where the nerve root has to come out through the anterior horn cell. You hit the NMJ and the muscle. So this is your classic compound muscle action potential, which you get from the needle electrodes which are placed over the muscle. And this is the picture of the D wave, which is elicited from an electrode placed in the epidural space. So changes in MEP introp are highly correlated with surgical outcomes. Even though intraoperative changes are seen in around 11.3% of major spine surgeries, neurological deficit is seen only when these changes are persistent. The other advantage of MEP over somatosensory evoked potentials is that it's a much more sensitive indicator of ischemia to the spinal cord. Not only does it pick up ischemia much earlier than SSCP, it's also a much more sensitive indicator of spinal cord ischemia. And for cervical spine surgery, it is considered standard of care, not only because of the implications of having a spinal cord injury at that level, but it will also help you to differentiate between a myelopathy and a radiculopathy. Now, the issue with motor evoked potential is that there is huge interpersonal variability in the baseline amplitudes. It can be as low as 200 for some patients, but for the next patient, you might get a value closer to 2 millivolts, 200 microvolts, can go as high as 2 millivolts. So there's a huge variability. And when you add anesthesia in the mix, that variability is only amplified. So most centers, that is mainly in Europe, where TCA and TIVA is really widely prevalent, they consider TIVA with propofol to be the standard of care. Many centers add in ketamine because ketamine is known to decrease the threshold for MAP response. Standard dose of volatile anesthetics, as with all evoked potentials, is generally looked down upon for MEP monitoring. So keep them, if you really want to use a potent inhalation agent, you have to keep the MAC below 0.5 and supplement it with a low dose of other intravenous anesthetics. But the truth of the matter is that actually any anesthetic that you use, apart from narcotics and ketamine, at a high enough dose, they are going to suppress the motor evoked potential. Okay. Neuromuscular blocking drugs also are generally looked down upon, but many centers do try to maintain a stable TUF ratio using infusions of muscle relaxant drugs, but generally it is prone to a lot of problems, so we don't routinely follow that. And transcranial MEP is also difficult to attain in some patient groups, mainly at extremes of age and patients who have pre-existing neuropathy or myelopathy. Now, when dexmedetomidine came onto the stage, there was a lot of excitement about its usage in anesthesia and even for neuromonitoring. Not only because it gives you a very stable hemodynamic plane that is very advantageous for spine surgery, but also because its mechanism of action seemed to be independent of cortical suppression. Because of the alpha-2 agonist action, it was probably less likely to impact the evoked potentials. So the initial research was actually quite a little bit of a mixed bag. Some authors found that it was compatible, dexmedetomidine was compatible with good MEP signals. Some people found that it actually abolished MEP signals. So actually the same rules for most anesthetics follows here also. If you give dexmedetomidine in a high dose, especially without any BIS or entropy monitoring, you are going to lose your evoked potentials. So what we generally follow is we don't give a bolus dose, we just go with the infusion, and it is most of the time compatible with evoked potential monitoring. So most of these talks about evoked potentials will have this mandatory table about anesthetics and their impact on the evoked potential. So I would just like to point out that apart from etomidate, ketamine and narcotics, almost all the anesthetics will have some effect. Dexmedetomidine also they've said has no effect, but our personal experience shows that dexmedetomidine has an effect. If in the higher dose ranges, MEP is also suppressed. So there are numerous anesthetic protocols for evoked potential monitoring. The commonest is probably the propofol-based TIVA, following either the Eleveld or Schneider TCI model, and it has to be combined with a narcotic. Potent inhalation agents also can be used. Some people combine it with dexmedetomidine, some people combine it with propofol, but narcotic is mandatory along with that. One of my colleagues actually uses potent inhalation agent along with lignocaine. So there's a lot of drugs that can be used to get a stable MEP waveform. And for using propofol TCI, it's better always to titrate from a lower dose to a higher so that you don't lose your MEP. And we always target a BIS value between 50 to 60 to ensure that the patient isn't too deep at the critical stages of surgery. So currently what I follow is that if you have an intact patient coming for a spine surgery, I would prefer to use a potent volatile agent combined with narcotic and dexmedetomidine. And of course, avoid muscle relaxants and nitrous oxide. We consider an arterial line to be mandatory, at least for all adults when there is instrumentation of the spine. And we have to agree with the surgeon preoperatively itself what would be your ideal BP range, which we have to maintain during the surgery. Now, if the patient is not neurologically intact, if there is already significant spinal cord compression, the story is a little different. We have to be very careful to maintain blood flow to the spinal cord at all times. And we don't use potent inhalational agents at all, because it is known to suppress even already marginally suppressed MEP. Using a potent inhalational agent is going to suppress it further, and you won't get any baseline. So avoid inhalation agents totally. You can use TIVA with propofol with a narcotic, and prefer to put a central venous access so that you can control the hemodynamics more acutely. So using a depth of anesthesia monitor is also mandatory. Placing a bite guard is very important. I've had too many patients with bite guards slipping out, biting on the tube, biting on their tongue. So these are all avoidable things. Avoid hypothermia with a forced air warmer, and be very careful of blood loss. You don't want to be caught with a low hematocrit and a lost MEP. That could look very bad, because it's very difficult to catch up on a low hematocrit very quickly. So now the known complications of MEP include seizures, tongue lacerations, arrhythmia, scalp burns, jaw fractures, and notoriously awareness. Other potential complications can range from headache to neuropsychiatric changes, which are thankfully not that common in our practice. And if you have a relatively uncontrolled epileptic, I think that is the only major contraindication for evoked potential monitoring. Now, briefly touching on EMG, more and more the electrophysiologists are using EMG intraoperatively to real-time assess whether your screws are damaging the nerve. So if you're having a free-run EMG going on continuously on your screen, when the surgeon places a screw and it's actually impinging on a nerve, you're going to have high activity on your EMG. Okay, that is one way of approaching it. The other thing is you can actually use your EMG to stimulate each pedicle screw. So if you have a nerve response with a current less than 6 milliamperes, that means that screw is too close to the nerve and it has to be taken out and repositioned. So thankfully, when you're using EMG, the only rule the anesthetist has to follow is don't paralyze the patient. But since it's always in combination with MEP, you have to follow the MEP protocol. So there's a lot of recent interest in looking at spinal reflexes to actually assess the integrity of the spinal cord. Now, the only one that we are actually following is looking at the bulbocavernosus reflex, especially in small children who are coming for detethering surgeries. Basically, the bulbocavernosus reflex needs to be maintained for your bladder function. So it's especially useful in children who already don't have voluntary bladder control. If you have a maintained bulbocavernosus reflex throughout your surgery, you know that it's not damaged. If you're not able to elicit a bulbocavernosus reflex at the starting of surgery itself, that's actually a poor prognostic indicator, and that child is very likely to have a lifelong incontinence issue. So the BCR is actually done by placing patch electrodes at the glans or paraclitoral region, and is monitored at the anal sphincter. And we generally say there is significant loss of BCR when there is 90% suppression of the H reflex of the reflex arc. And TIVA or low-dose inhalational agent are generally used when you're monitoring BCR. Now, probably the most important part of this talk is how to troubleshoot. So in our scenario, when the electrophysiologist says that there is a suppression of the MEP, the surgical team invariably turns around and looks at the anesthetist or looks at the monitor. So sadly, the onus on managing the MEP and the response primarily lies upon the anesthetist and the electrophysiologist. So when these kind of issues pop up, it's nice to know what is the pattern of loss of MEP. So a global loss, if the electrophysiologist says all the potentials are suppressed, that means it's probably something likely to do with your anesthesia or other physiological parameters which are in our control. If the electrophysiologist says that it's partial, that is, you have only a loss in the lower limbs or only in one upper limb, it may be a surgical issue which the surgeon also has to troubleshoot. But then it doesn't mean that the anesthetist doesn't have any role. The anesthetist also has to play their part in ensuring that the damage is limited. So the basic The basics for this are maintaining a stable depth of anesthesia throughout the surgery using a BIS. So at the critical stages of surgery, make sure your BIS is between 50 and 60 and you will be safer. You have to be very proactive in treating issues like hypothermia and blood loss, because you can't get the temperature up suddenly and you can't get the hematocrit also up suddenly. So we have to be very proactive, recognizing blood loss and being very proactive with warming. Hypoxia and hypotension we can deal with, thankfully, reasonably quickly. And we have to make sure that these are stable throughout, especially when you have issues with your evoked potential. So some of the steps that we do are decreasing the depth of anesthesia if you have a loss of potentials, and using inotropes or vasopressors to make sure that the spinal cord blood flow is optimal. Now, just for completion's sake, there are two phenomena that have been described recently in literature. One is that of anesthetic fade. So it has been described that when you're doing very long surgeries, spine surgeries in prone position, you find that there is a gradual decrease in your MEP amplitudes. So the explanation for this is not clear, but this has been blamed on changes in pharmacodynamics due to hypothermia or due to the metabolism of propofol in prone position. The other thing is more understandable, that is a fade-in phenomenon, where your MEP amplitudes slowly decrease over the course, slowly increase over the course of the surgery, maybe because some patients may be sensitive to the effects of neuromuscular blocking drugs, and as the drugs slowly wear off, your MEP amplitude actually starts to go off. And the other possible explanation is that if you have cases which have significant hemorrhage, the propofol levels actually start to drop because of loss from the surgical site, resulting in a fade-in of MEP. So that brings it to the end of my talk.
Thank you, sir. I would now like to call upon the speakers of the previous two lectures, Dr. RAMKUMAR VENKATESWARAN and Dr. PANKAJ KUNDRA, onto the stage. The three topics are now open for discussion.
Hello, sir. I'm Ravitej from KMC Manipal. My question is to Dr. RAMKUMAR, sir. So this is with regard to anterior thoracic spine surgery. So my question is ETCO2 reliable? And if not, how frequently should we do PCO2, ABG analysis? And my second question is, if all the conventional measures that you mentioned fail in bringing down the ETCO2, can I inflate the lung more, or is there any other measure?
Okay, I'll take your first question first. Intuitively, I would think that ETCO2, and if the surgeon is going to be collapsing any part of the lung, which he would, whichever the approach to the spine, I think there's now going to correlate with the arterial carbon dioxide tension. And I think for such major surgeries, you will definitely have an arterial line. So I think at the lowest index of suspicion, you have to repeat the blood gases. Right? I wouldn't go by the ETCO2 alone to look at the carbon dioxide elimination. I do not know whether that answered your first question.
But then how frequently, sir?
As I said, intuitively, I cannot give you a time interval. Okay, it depends on if you suspect that there's a problem. You find there's a tachycardia, whatever other signs and symptoms are there for a hypercarbia to be there. I think you need to repeat it. A few extra repetitions is not going to cost much in an overall major surgery like that. So I think it's left to the anesthetist too. I don't think there's any particular interval at which you repeat it, unless somebody who does more thoracic surgeries has got an opinion on that. Any frequent? Yes, PANKAJ, yes.
So ETCO2, CO2 is a very highly diffusible gas, right? So even if you have a patient with pneumonectomy, if you do an ETCO2, the values are not going to alter too much. The difference is going to be very, very narrow. So you can use ETCO2 and you will have a trend. So if you have done a blood gas and an ETCO2 and you are having it, you will know how much is that CO2 gap which you are anticipating, and that gap will remain the same till the end of surgery.
So would that be true even if one lung is partially collapsed? Okay. Thank you. Yeah. And what was the second part of your question?
Lung inflation, high frequency doesn't work in bringing down the PCO2. Even the high PEEP doesn't come down. Can I inflate the lung further? Or
Definitely. I think there are a few more strings to your bow. One thing is you can ask the surgeon to temporarily stop whenever he or she can. You should inflate the lung a few times. Okay, try to get that carbon dioxide down. The other thing is, if nothing else works finally, you may have to temporarily clamp the pulmonary artery to that side. These are only two suggestions that I have here.
And
anything Pankaj or Matthew want to say? Or anybody in the audience? This light is disturbing. Can we have it off? Yeah. I can't see the audience here. Those are the only 2 points that I have to add. Thank you.
Actually, I just wanted to add something to his question. Usually, from my experience, I've noticed that, as Pankaj sir said, that EtCO2 and PCO2 usually correlate pretty well, even if it is one lung ventilation. The only problem is you have to ensure that you're actually ventilating the dependent lung adequately. So if it is inadequately ventilated, or you have some problem with your positioning of your DLT, then more likely to have this mismatch is what I've noticed.
One thing I have read is that by and large, it's the CO2 elimination that suffers more than oxygen transfer when there is a ventilation perfusion mismatch. So anyway, Pankaj says that even in a collapsed lung, it does correlate. So we'll take that. So I have nothing more to add. Yeah.
And I have one more question to Matthew, sir. Sir, among all the depth of anesthesia monitoring processed EEGs that you've used, which one do you think is the most reliable? And is maintaining 50 to 60 on a BIS or an entropy safe, or not being on the border of awareness?
Yeah, that is true. I have primarily experienced BIS. I think entropy for a short time when I was in Manipal, I've used entropy. There is literature to show that maybe BIS is not as reliable as it is. So people have recommended keeping the BIS below 50. In my personal experience, I've not had any awareness so far during any case where we've actually used neuromonitoring, thankfully. Even we've had the BIS hovering transiently around maybe even slightly inching beyond 60 at critical junctures when everybody's anxious and there's no MEP, or you're not having any lower limb MEP. We have even taken that risk. It's not something I recommend, but touch wood, we've not had any issues. It's only a personal experience, but BIS is only a tool. Ultimately, you have the added safety of the patient not being paralyzed when you're doing any evoked potential monitoring. So if you really come up on a situation where the patient starts moving other parts of their body, that's a solid red flag. You have to deal with that. But otherwise, BIS is only a tool. It helps you to maybe say that anesthesia is not the cause. It's an objective tool to say, to show to the surgeons and the electrophysiologists. If you have a BIS around 50 to 60, I think you can definitely tell them, see, this is it's not anesthetic depth that's a problem, it's something else. Okay, I think in my personal work, I feel that is what's important. But then looking at the patient as a whole and not just looking at the numbers is also important.
Any more questions
I
from the audience?
have one. Good morning. Thank you for the lovely talks. I'm Dr. Nisha from KMC Manipal. My question is directed to Dr. Matthew. When we talk about spine surgeries, we are often concerned about multimodal analgesia, and I think we talked about opioids and dexmedetomidine. What is in your experience, does magnesium have a major effect? Because a lot of people do use that, and I have used it in scoliosis surgeries as well. But that was in the pediatric population. So in the adult population, have you had any problems with it?
Sorry, I can't really answer that because I've not really used magnesium as a part of the analgesia protocol. We do end up relying a lot more on narcotics, and our surgeons are quite open to place epidurals for us post-op. Right. So we have not had any major issues with pain. So we've not had to go in the direction of having to use, other non-conventional analgesics like magnesium or maybe ketamine. Maybe rare conditions where we've not been able to place an epidural, I've had to use ketamine post-op in small doses. Not magnesium,
as infusions,
actually. As an infusion. As an infusion.
Right.
Can I give you a small solution?
Sure.
So we had patients who were coming for laminectomies. And what happened was that if you try to place epidurals post-op, the whole space is disrupted. And even if you put on a catheter, everything is going to spill out. It's never being contained. So we published this in 1998, anesthesia analgesia. What we used to do was give morphine epidurally about 1 hour before surgery. So it takes about 60 to 90 minutes for morphine to fix to the opioid receptors. Once the morphine is fixed, then the action is somewhere around 24 hours. Then you don't have to bother about anything else.
Yes, I think we often do that. I think we follow intrathecal morphine instead of
intrathecal or epidurally, whatever you
Yes.
feel comfortable.
Yeah, I was
and
just wondering.
not only does it help you in post-op analgesia, what we had seen in our group of patients is that the laryngoscopic intubation response was completely blunted. So that's the magnitude of analgesia effect which you give, provided you allow sufficient time for morphine to fix to the receptors when you give it by that route.
Thank you, sir. So, in my experience in the pediatric population, we've not had much of a problem with magnesium. That being said, literature seems to be giving us, it might affect the intraoperative monitoring. So I just wanted your opinion. Thank you.
Any more questions? I request Dr. Anita Shenoy to kindly come on the stage to felicitate our speakers.